Thank you, Chairman. Next, we will be hearing House Bill 7611 by Representative Blazajewski. I don't see him here. It is an act relating to health and safety, licensing in healthcare facilities, establishing limits on the maximum number of patients that may be assigned to a unit's registered nurses in particular healthcare situation. So he is not here, so I guess we'll go right to,
Linda McDonald? Is she on?
I don't see. Yes. So I'm going to call up Linda McDonald, RN from UNEP, and Helene Macedo, RN from UNEP, who are speaking in favor.
We have two others, too.
Welcome.
Thank you. Just want to appreciate your long night here. So my name's Linda McDonald, President of the United Nurses and Allied Professionals. We now represent about 7,200 healthcare workers, mostly RNs and other allied health professionals. And I say this because it's important. I'm not just saying this to just like state it as part of my name, but we are all bedside healthcare workers. We are not managers, we are not administrators, we are the workers. So Representative Blazajewski was not able to come, but I do want to recognize his help with this bill. So we want to thank him, the chairman, and the rest of the committee. And we always appreciate the opportunity to present this important patient safety and quality bill. We will be brief tonight. Just patients in hospitals in Rhode Island are sharing their nurse with too many patients. This practice is dangerous, and under such conditions, mistakes, errors, and burnout become more likely to occur. This bill will ensure that patients receive the level of professional nursing care and attention they need when they enter the hospital. The Patient Safety Act will dramatically improve patient safety in Rhode Island by setting a safe maximum limit on the number of patients assigned to a nurse at one time, while providing flexibility to hospitals to adjust nurses' patient assignments based on specific patient needs. The law specifies safe, evidence-based limits on nurses' patients' assignments with different maximum limits for each patient care area, like the emergency room, maternity, med-surg areas. For certain areas, like the emergency room and maternity, the law specifies different limits based on the nature of the patient's condition. A trauma patient comes into the ER, they're going to get 1-to-1. A stable patient comes into the ER, they're going to get a different ratio. This is built in. To provide flexibility in RN patient assignments and to account for patients who require more care, the Patient Safety Act establishes an acuity system, which is in the bill on page 3 to explain the different parts of the acuity system. And this tool will measure the illness level, how sick the patients are in a particular unit or a particular shift. And based on the acuity of the patients assigned to a nurse, the maximum patient assignment would be reduced if that patient requires more intensive care. 7611 also provides flexibility in the ICUs, where a registered nurse may accept a second ICU patient if the nurse assesses that the patient is stable based on established criteria.
That's 2 minutes.
I'm presenting the bill, so I get a little bit more.
Yep,
but
sorry.
I'm almost finished.
My
too.
mistake, sorry.
Not a problem. Not
Apologies.
a problem. Right now, the only flexibility we see is used to increase patient assignments. We do not see, after all these years of us testifying and our opponents testifying, any decrease in these patient assignments, only increase. The system in place now gives the shift with the least experience and skills the highest patient assignment. And I just wanted to mention a Memorial Hospital nurse looking for work after her job was eliminated, went to Kent Hospital talking about the night shift, and she was told by the manager that she could expect as a float nurse on those units 9 patients. 9 patients. This is not made up stuff. This is just truthful information. Improved limits will decrease, not increase, delays in the emergency department, as we have heard in the past from our opponents, and it will be cost-effective due to improved outcomes. And I just want to say that the UNAP is part now of a Northeast coalition of nurses, Pennsylvania, New York, New Jersey, Connecticut, Rhode Island, Massachusetts, and Vermont, all working on various forms of safe limits. And Massachusetts will put this question of safe patient limits to the voters of Massachusetts this November. The polling data currently shows very favorably for the passage, although the opponents are spending millions of dollars to defeat this. So I want to thank you for your time. I will be sending the committee a link to dozens of prominent studies that show these limits, and I will also be sending a remarks statement to you. And just before I close and pass this on, we still feel that this is an issue of misplaced priorities. This has nothing to do with good patient care. We are seeing no improvements in staffing. And again, we represent frontline caregivers, and we are the ones who are taking care of your patients on the night shift and off shifts where our unsafe staffing forms are still going unnoticed, unresponded to, with you have to do with what you have. So I pass this on. We have three members talking about three different systems, and they will keep to their 2 minutes.
Thank you very much. Does anybody have any questions for this
Yes, I
witness?
will speak on the bill if you have questions.
Thank you very much, yes. You can speak. Now we're going to adhere to the 2-minute limit now. Thank you.
Except for the main.
Except for the main opposition, which will be after you.
Thank you again for hearing our bill tonight. I'm Helene Macedo, and I am a registered nurse at Rhode Island Hospital, and I'm a vice president of UNAP. At Rhode Island Hospital, the unsafe staffing forms continue to come in. Year after year, we present you with a stack of unsafe staffing forms. The staffing levels have not improved. We hear year after year from hospital administrators saying that this bill would not allow an RN to have the ability to participate in their assignment. When we fill out these unsafe staffing forms, before the unsafe staffing form is filled out, a call is made to a supervisor, a manager, or a resource nurse. The response is either you need to do with what you can, or the call just doesn't go answered. For example, at our level 1 trauma center in our emergency department, this is a real example of what an assignment would be like. So we have 6 trauma rooms. They should have 2 patients, 1 nurse to 2 patients. All 6 rooms were tripled. They're stocked for 2 patients, they were tripled. A nurse had a patient come in having a stroke. Before she could even attend to that patient, the next patient came in with a gunshot and stab wound. And before that patient was even attended to, the next patient was having a heart attack. That's one of the trauma rooms. And just picture that happening in the other 5 rooms. We have, and I want to just ask, how do you call that delivering health with care? Our psych units on a day shift, 1 RN, 7 patients. 4 patients, a code gray was called, which means that they need security intervention. An RN was punched in the face. Again, how is that good patient care? Our ICUs, same thing. They should have 1 nurse to 1 patient. Most of them are doubled up. It's the patients that are suffering by not having this bill passed. Thank you.
Next, I'd like to call up Rose DeNoyes, RN, and Lynn Blaze, RN, both from UNAP. Both are in favor and are speaking. Welcome. Make sure your buttons are up.
Hi, my name is
Thank you.
Lynn Blaze. I am from Our Lady of Fatima Hospital, Charter Care Prospect System. I'm a registered nurse for 34 years, have always been at the bedside for those 34 years. I'm speaking in favor of this bill for several reasons. Oh, sorry. I'm speaking in favor of this bill for several reasons. I have been here, coming to the State House for many, many years. I've been a union activist for as long as I've been a nurse. 10 years ago, we were here talking about mandatory overtime and how mandatory overtime affected patient care and patient outcomes. And the hospitals then spoke adamantly that they could not do away with mandatory overtime, because if we got rid of mandatory overtime, the patient care would suffer, the hospitals couldn't survive. 10 years later, no mandatory overtime, hospitals have survived, patient care is better because of that. We're in the same boat today. We are here because the patients need us to be here. We were in a program at the hospital this week, and it's ironic. I'm a patient experience, our buttons that we're wearing. Well, we are the patient experience. It's the people at the bedside that get the patients in and get them out as safely as possible. We know what they need. We see their changes minute to minute, day to day. We know what we need, and what we need is safe staffing. And we need that by legislating minimum staffing levels. Massachusetts has done it recently in their ICUs with the one-to-ones, and it's working there, and now they're looking to move it forward. I look at it when I'm told that, well, we can replace an RN with a CNA on our Geri Psych unit, and it's okay. I have data, just a short snapshot, where we increased our RN population on our geriatric psych unit, and our falls went down, our code grays went down, patient injuries went down, staff injuries went down. They go back to the old way, code grays are going to go back up, patient injuries are going back up, staff injuries are going back up. A nurse is not a nurse. We all have our specialties, and we all know what we need to do. So I'm going to be here every year until we get this passed, because our patients need it.
That's
And-
2 minutes.
And we need you to get it done. Thank you.
Is your microphone up?
It's on now. My name's Rose Genoyer. I am president of the Kent Local, and I have been a Kent employee for 32 years, and I have never seen it as bad as it has gotten. I understand the need for flexibility. Nursing, that's what we do. We have to be flexible. But when they say flexible, what comes with flexible is, I'm sorry to say it, but abuse. I have nurses, and I have a story here to tell you, and it's my job to make you see this story. Typical unit, which has just been comprised, 2 units have been brought together. It's not set up to be this way. One nurse with a graduate nurse with her, okay? 6 patients on the day shift. First patient is an 80-year-old male. He's got an acute EKG changes, new shortness of breath. Tropes are increasing, cardiology consult was called, ended up with an emergency cath. Along with that, she was responsible for 2 post-op patients, one on day 3 with a gastric bypass that landed up with a bleed. The GI X-ray CAT scan was called. Patient landed up having to have fluid balances done. Day 1 on a surgical patient, lysis of adhesions. Patient was on morphine, Tylenol, had nasogastric tube outputs while trying to maintain blood pressures with poor effect from the morphine and unable to use the Dilaudid for pain control. 4th patient was a kidney issue. Manager was notified because the patient, the room was unable to maintain that patient. They needed special equipment that they didn't have. Health insurance was causing a lot of stress for the patient at that time, and patient not knowing whether or not they were going to be able to do anything, and the nurse was involved in that. 5, a diagnosis of an end-stage liver disease, out of ICU, worsening lab work, couldn't get there, landed up having human infusions for minutes. 4 hours. You need to understand that that's what it is. It's not what they say it is.
Thank you very
Not on the
much.
floor.
Thank you. Does anybody have any questions in the committee?